Sorry, I'm a couple minutes late, everyone. I'm not in my usual environment. I just got to a hotel room and could not get the internet going. So you'll see me wobbling a little bit. I'm holding holding my phone up for the moment. But we wanted to get going. We didn't want to keep any of you waiting. So I've got Brett Hawes here again tonight, joining us in Networking Nutritionists. Hi, Brett. Thank you for being back here. And tonight he's going to be talking about gut infections in clinical practice, which I know is a topic so many of you have brought up. So I'm sure there's going to be some really useful information shared tonight. So I won't filibuster at all. I'll let you jump right into it, Brett. I know you've got a bunch prepared for us, and I'll let you take it away.
Okay, awesome. So welcome everyone. Hello, my name is Brett. I'll do a bit of an intro here in a second. And I've got some really good stuff to share with you tonight. So just stick with me. I originally planned this as a 90-minute webinar, just so you know. So just stick with me, okay? It might not take us 90 minutes, but it might take us 90 minutes. And of course, if you have any questions, Veronica might drop off at some point if her internet fails or what have you. So please do just pop those in the Q&A box as opposed to the chat box, and then I can get to those periodically through the presentation. So what I'm going to do is just share my PowerPoint here. Okay, and you should be able to see that. Is that right? Yeah.
Yep,
okay,
looks
awesome.
great.
Let me just get this oriented. All right, so tonight we're going to talk about gut infections in clinical practice. Obviously, we're all professionals here. Most of us at least have a background in nutrition, and I know many of you have additional modalities and training in that. So there might be some things that I'm just going to sort of gloss over because I'm going to assume that you know that. And then once we get into other areas here, we'll dig a little bit deeper and I'll expand on those things. So for those of you who perhaps have not met me before, my name is Brett Hawes. I am a certified functional medicine practitioner and a clinical nutritionist. I have been in practice for around 18 years now, so long time. Sometimes I look back and I'm like, wow, it's been that long. And my focus is really gut health, hormones, and autoimmune disease. That's sort of my wheelhouse, and I would say about 90% of my practice is there. I deal with a lot of chronic and complex issues. Oftentimes my clients have gone through the medical system, the specialists, other practitioners and whatnot. And then I land up working with them usually for 6 to 12 months. And we sort of get deeper and deeper into what's going on. I am also a professional educator. So I'm a faculty member at the Institute of Holistic Nutrition. And I have a podcast, which is going for about 5 years now. And so we've released lots of episodes, and we consistently rank in the top sort of 200 podcasts for alternative medicine, okay, or alternative health. So yeah, if you want to check that out. Just lightning fast, I'm not going to labor over this too much, but just, I've worked with a lot of supplement companies in the roles of mostly education, but also advisory roles, formulations, etc. And then Detox Project and NHPPA, those are my sort of rah-rah activist groups that I love. And I've done a lot of work in that area as well. So for tonight, our learning objectives really are exploring the microbiome, how poor digestion leads to gut infections, dysbiotic patterns of various gut infections, challenges and limitations of functional lab testing, which is a big one. We'll talk a little bit about comprehensive stool testing, SIBO, and organic acids testing. And then we'll spend a good chunk of time on biofilms and talk about the 5 stages of development, how they contribute to chronic infections. And then I'm really excited to share some novel approaches and maybe just a different way of thinking about things when it comes to antimicrobial therapy, probiotics, and just our view of infections, generally speaking. And lastly, we'll wrap things up. This is obviously, we've got 90 minutes here. We'll talk about a framework, and a very basic framework at that, right? So we're not going to go super deep into the framework, but just to give you some sort of idea of how to approach gut infections in practice, because what I see out there is people just blasting everyone with antimicrobials and or antibiotics, and then trying to clean up the damage after that, right? So we're going to sort of flip some things on their head tonight. So I always like to ask people, what is the microbiome? And for those of you who are tuned in live, feel free to put that in the chat box. When you think of the microbiome, what do you think of? Like if someone walked up to you and said, what is the microbiome? I'm curious to know. And if people are shy, I will happily jump into it. Let me just check the chat here. Okay. So when I think of the microbiome, and I've really changed my thinking around microbiome in the last couple of years, I really refer to the microbiome as the organisms that live in and on us, right? So they live in and on us. Because when you speak to most people, the microbiome is simply gut bacteria, right? And that's kind of where the conversation stops. But if we actually expand our view on this, we have different microbiomes as part of our overall microbiome. So we can see that we have an oral microbiome, and the legend on the left here, you'll see that the oral microbiome, for example, differs from the gut microbiome, which differs from the skin microbiome, vaginal microbiome, and so on and so forth. And so, of course, I don't have to tell you this, that the current research on the microbiome as a whole is absolutely exploding. And, you know, you can see some of these conditions here on the left-hand side of my screen, obesity, metabolic syndrome, diabetes, and the microbiome, which is huge, right? I was actually working with a probiotic, they're like exclusive probiotic manufacturer in Korea, and they have identified certain strains that control blood sugar. And they've also identified other strains that modulate bone health and things like osteoporosis. So, you know, psychiatric disorders, another huge one. So we'll touch on that very, very briefly tonight. And then, of course, our skin microbiome. So allergies, acne, psoriasis, eczema, et cetera, et cetera. Now, what's interesting, I'll just point out one thing here anyway, actually two things. The first one is, you know, you look at the placenta, which is interesting, and we've always thought of the placenta as this very sterile environment, and turns out that newer research is uncovering that it is populated with certain bacteria, and we'll touch more on that in just a minute. The other thing I want to pull out here is the oral microbiome. And what's very interesting is on a lot of the stool tests that I've been doing recently, I've started seeing bacteria that are usually found in the oral cavity that are actually landing up in the stool, right, and contributing to bacterial overgrowth and dysbiosis, right? So very interesting there. I'll expand on both of those points in just a second. So just a very short background here. When we look at the human microbiome, and let's just sort of laser focus a little bit more here on our gut microbiome, what we'll see is that essentially we have more bacterial DNA than we have cells in our body. These organisms outnumber us by about 10 to 1, but in total, they only weigh about 4 pounds. And 90% of our microbiome is in fact bacterial, but what you will see is we also have protozoa, yeast, we've got viruses, we've got fungi, and all sorts of other organisms there. Real quick slide here. I really don't have too much to say, especially because I'm talking to health professionals here. We've got quote unquote good bacteria, and I don't like to use the word bad bacteria. I prefer to use the word opportunistic bacteria, right? So there's a reason why we're born with candida. There's a reason why we're born with these so-called pathogenic bacteria. And part of the reason is we need them there in very, very small amounts to sort of flex and train and keep our immune system toned. Because I'm sure you can imagine if we'd never ever seen candida before, and all of a sudden we get a candida infection, that could be potentially fatal, right? Because your immune system would just never have seen it before. So obviously we need a balance between those things. And we'll talk more about that obviously as we move on. So when it comes to our microbiome, as I said before, we've got these normal or what we call commensal bacteria. We have opportunistic bacteria, fungi, yeast, viruses, and I think the jury's out on parasites, right? Like, you know, are parasites a normal part of our microbiome? What I've started seeing on stool tests now is parasites are being detected, but they're within the normal range, and they're not actually causing any problems at all. So I think there's a conversation to be had there, which is sort of outside the scope of what we're talking about tonight. However, 90% of the gut microbiome are made up of these normal or commensal bacteria and then opportunistic bacteria. And the problem really becomes, you know, when this whole web or symphony of organisms become unbalanced, right? And that's where problems start to sort of ensue. So The highest variety of strains that we've identified, in other words, the variety of organisms that we've identified in the gut, are around 300. Now, some of the previous research went up to 500, some even 1,000, but much of that is outdated and sort of looking back 15 to 20 years. We'll expand more on this point when we look at some of the stool tests and some of those sample reports in just a second. Now, most healthy adults have between 125 and 200. I have yet to see anyone up in the 250 to 300 range. However, when we consider these populations like the Hadza tribe from Tanzania, for example, the last of the sort of hunter-gatherer tribes, and then also we've got the lost tribes of the Amazon, they've actually done extensive research on their microbiome. And what do you know? They have anywhere from 100 to 150 extra organisms in their gut, which is kind of interesting to think about. I think part of that has to do with them living close to the land, close to the soil, whole foods and all that. But I think also they're not exposed to chemicals, to things like Roundup and glyphosate, antibiotics, and so forth. So interesting. And also both of those populations have virtually zero bowel disease, which is kind of interesting. So bacteria also differ from small intestine to colon. So that is important, especially when it comes to things like stool testing versus SIBO testing and so forth. And there are 4 main phyla in the human microbiome: Bacteroidetes, Firmicutes, Actinobacteria, Proteobacteria, and there are others. All right, so we'll come back to some of that in just a second. So as I said before, we always thought that, well, I'll say relatively sterile at birth, right? And that is relatively sterile. As I said before, the placenta does have some bacteria, right? So it's not completely sterile. The baby receives mother's microbe as it enters the birth canal. This is really where most of the population happens. And of course, that brings into question the impact of cesarean sections, where I think now around 30 to 35% of women are opting for C-sections instead of natural births, right? So that's by choice. Further received through breast milk. And of course, development continues then to be governed by diet and environment. But a lot of the new research is suggesting that the microbiome is relatively, and I will emphasize that word, relatively fixed after the age of 3. So nutrition in the formative years, very, very important. When I say relatively fixed, we can modulate the microbiome, but I think if we had to put someone in a bubble and just remove all inputs, whether it be dietary input, probiotics, etc., you'd probably find that there's this resting position, if you will, for the microbiome, and that gets very difficult to change, right? So obviously, we know it influences many body processes, which I discussed before. So digestion, nutrient synthesis, particularly the B vitamins, vitamin K, a lot of neurotransmitters, which I think might be coming up, gut barrier function, immunity, neurotransmitter synthesis, and metabolism, which ties into mood and brain function, general metabolic function, and of course, blood sugar regulation, which we discussed before. All right, so that's really a sort of lightning fast overview of everything, and I'm sure that most of those points you're probably familiar with already. So let's dig into some, let's get into the infection side of things, right? And, I always, as a practitioner, I always ask why, right? So why? So why does someone have this? And then go back. Okay, why did they have that? Go back. Why did they have that? And I think when you trace back a lot of these infections, you will see that poor digestion is in the fold in some way, shape, or form. So when we think about digestion, it's always important to remind ourselves that it is one-way traffic, right? So we've got food coming in, and digestion is really a process of taking food particles that are very long or complex and breaking them down to shortest, and then absorbing these amino acids or simple sugars or fatty acids and whatnot into the bloodstream, okay? Now, of course, if there's any problems higher up, for example, I'm not chewing my food properly, that is going to have a cascade effect going down, and it's going to put pressure on the stomach, which will then put pressure on the gallbladder, the pancreas, et cetera, et cetera. All right. So it's always important to just sort of look back up the chain. And as I said before, we're now starting to see dental infections or oral infections, and these bacteria that are really reserved for the oral microbiome are now landing up in the stool, right? Which is kind of interesting. So Low stomach acid, right? We know that stomach acid has many different roles, and one of them is to sterilize pathogens. So if I have low stomach acid, and that could be for a million different reasons, which we're not going to get into here, but low stomach acid doesn't sterilize pathogens, and that really opens the gates, right? So that's one mechanism there. Low stomach acid does not trigger pancreas, right? And it doesn't trigger the gallbladder. If we're not triggering the pancreas, that means we have low enzyme output, okay, which means I don't break down my food properly. If I don't break down my food properly, who finishes the job? Bad bacteria, right? And they're going to start to get overgrown. We also have poor bile flow. Okay, now the gallbladder, it's really only in the last few years that I've really dug into the gallbladder and just how critical it is. And you look at things like SIBO, for example, which we'll talk about tonight, and pretty much every single person that has SIBO has poor bile flow, which is kind of mind-blowing, right? Now, when we think of bile, usually what we think of is digestion of fats, right? And that's kind of where the conversation stops. But what we also need to remind ourselves is that bile is an antimicrobial. It's a very powerful antimicrobial. Bile is also an alkalinizing agent. And lastly, bile has mild laxative properties. So if bile is not flowing, we have motility issues, we have infection issues. Obviously, we're not digesting our fats. And now we start to have problems with pH as well, right? And that's next. So changes in pH. Now, when changes in pH happen, whether it's too high, too low, and whatnot, basically you're going to have a whole bunch of things that are going to happen there, because certain organisms thrive in certain pH ranges. And as soon as you step outside of that, one, we lose our beneficial organisms because they get killed. And two, we create this favorable environment for pathogens to kind of take hold and start to grow. So this all together relates or eventually can pave the way to leaky gut, right? Autoimmune diseases, food allergies, systemic toxicity, inflammation, and of course, much, much more, right? Once the gut lining is damaged, there's a whole host of things that go wrong from there. So let's talk about some dysbiotic patterns. And the first thing I want to do before I get into any of this is I want to relay why it's important to identify these patterns, right? So why would I want to look at patterns? When you get into diagnostics, not that we are diagnosing anything here, but if you speak to a doctor that does diagnostics, pattern recognition is very, very important for them, right? So identifying patterns. And for us, identifying patterns serves a few different purposes, right? The first one is that it is actually going to guide the testing that you're going to do. Right. So this whole notion of just, I see this a lot in the US, especially practitioners just run a battery of tests right out the gate. Right. So they'll spend $5,000, $10,000 on testing just to kind of have a look. I don't work with people like that. Maybe you do. Maybe your clients have thousands and thousands of dollars lying around. But most people, they're coming and they're sick. They need help. They're spending money on your fees, on supplements, on functional lab testing as well. And that, the costs rack up. So the way I look at it is I always say, well, based on the patterns that I'm seeing, is it better to run a SIBO test? Is it better to run a stool test? If I'm going to run a stool test, what's the best one for this particular situation? And so on and so forth. The second thing is understanding and recognizing these patterns will also help to dictate the treatment guide, right? Or treatment options. So in other words, what does that road look forward? What does that road ahead look like for that person? If I'm going to create a roadmap for them and work in phases, it's really good to know what these patterns are, then test, get confirmation, and then proceed from there. And so lastly, we would use this as a compass, right, to guide us, because once you understand these patterns, then what will happen is as the person starts to get better, you can start to see the patterns are getting better. And that means that, again, if people have oodles of money, they can keep retesting and retesting and retesting, but that's going to rack up to thousands of dollars. So what I find myself doing is running tests in the beginning I work, and maybe 6 months or a year down the line, I might run a follow-up test to sort of say, hey, you know what, all of your symptoms are clearing, these patterns are clearing. Let's now do a follow-up to sort of see what's left over as far as functional lab testing goes. Okay, so what this also does is the patterns together with the testing will keep you honest. It will also keep your client honest as well, and it's a good gauge and a good benchmark for you to start off with. Okay, so some of these patterns. Let's talk about IBS and SIBO. For those of you who might not be aware, SIBO really drives most IBS cases. And of course, we've got different types of SIBO, which we're not going to get into tonight. But some of the things to be aware of here, obviously, most people with SIBO are going to react to high FODMAP foods. That would include your fructose, your lactose, your fructans, galactans, and of course, polyols. People usually have identified this, but I still see people eating healthy diets, right? There's a lot of healthy food on there. Okay, for sure. Avocados, what do we got? Beans, lentils, we got garlic, onions. There's nothing wrong with these foods, but people haven't put the pieces together where they eat these healthy foods and it's just not healthy for them, right? And it's causing all these problems. So reacting to high FODMAP foods, I see that a lot with people with SIBO, and they still keep eating garlic, still keep eating onions, and they can't figure out why they've got bloating and indigestion. IBS following a bout of acute GI infection. So this would actually be post-infectious IBS, which is the third or fourth type of IBS. These are all questions that you can actually ask your clients, by the way. And in the masterclass that I have, we actually have a bunch of questionnaires where you can actually sort of say, hey, give this to your client, get them to fill it out, and you can kind of score them a little bit better. All right. So temporary improvement in IBS symptoms after taking antibiotics. How many people are on these cycles, right? Where, I got this infection and a flare up. I take the antibiotics, I feel better. And then a couple months later, boom, I got another flare up. I take more antibiotics. So when people tell you that their IBS symptoms get better after taking antibiotics and then they come back, that's a pretty good indicator that you're dealing with someone who has SIBO. And of course, the more boxes that they check off here, the more confirmation you have. A worsening of IBS symptoms from ingesting probiotics. Okay, especially those with FOS, which is a fructo-oligosaccharide. Right now, you can see fructose is at the top of the list for FODMAPs, right? And FODMAPs are fermentable oligosaccharides. So this here is telltale, right? When someone says, I react to probiotics, I feel better after taking antibiotics, I react to these FODMAP foods, that is a person right there that I'm almost guaranteed that you have SIBO. And lastly here, eating more fiber increases constipation and other IBS symptoms. Right, so this is a very short list, but I've really pulled out the essence. And the more boxes here that people check off, the more likelihood it is that they have SIBO. Okay, more on that in just a little bit. So Candida, yeast and mold. I don't have a slide for that. I'm just going to sort of speak about that. The obvious ones, right? So people are sensitive to sugars. Okay, they're sensitive to baked goods, to yeasted stuff. What else? Anything with anything that's breaded, right? So wheat. A lot of people don't realize that the Candida antigen is very, very similar to the wheat antigen. And so oftentimes what you'll find is your body starts reacting to wheat when you have Candida that's overgrown. Okay. Now, there's other patterns here, because what I'm sharing with you, I'm sure you all know already, but there's other patterns that I've seen, and people reacting to sulfite foods. Right, so sulfites, that could be from the deli, so anything that they eat from the salad bar or deli food or whatnot, they react to those foods. They also react very, very badly to red wine. And red wine is a big problem because, of course, you've got the alcohol side of things, you've got the fermentation side of things, the high sugar, and then you've also got sulfites, right? So I find that almost every person with Candida will tell me that, yes, they're sensitive to alcohol as a whole, but red wine is an absolute killer. And they can get drunk off a glass and a half of wine. So the question is, why sulfites, right? What's going on there? And cheese is another one. right? So people with candida always have cheese issues. But the sulfite connection there is that when you look at candida produces a lot of these just metabolic byproducts and toxins, the most predominant one being something called aldehyde. And aldehyde is an alcohol-like substance that is detoxified down a certain liver pathway. Well, what do you know? Sulfites are detoxified down the same pathway, right? So you find that anything that's detoxified down that liver pathway people are going to show up as being sensitive to that. All right. They might also be sensitive to mold, to actual mold in their environment, moldy food, mold in the air, mold spores, anything like that. Bacterial dysbiosis is obviously very general. There's no clear patterns for that. But the one thing I want to say about this is when you think about the obvious ones like gas, bloating, abdominal pain, abdominal distension, could be constipation or diarrhea. Usually what happens is people with bacterial dysbiosis will tell you that they notice that those symptoms are in direct response to food ingestion. Okay, so I'll just say that again. It's in direct response to food ingestion. So in other words, I eat the food, and I would say, based on what I've read in certain textbooks and studies, anywhere between 80 to 90% of those symptoms are a direct response of microbial activity in the gut. In other words, you eat the food, they ferment those foods or digest the foods or whatever, and the microbes themselves are producing gas, which causes pain, et cetera, et cetera. Okay, so that's a very loose pattern there for bacterial dysbiosis. Parasites are very tricky. Okay, very tricky. And I do have a slide deck for that. And what I've pulled out is some of the big ticket items here. So chronic diarrhea is often a very, very big clue. And what you're going to find is people are going to take things like Saccharomyces boulardii, or they're going to take fiber, or they're going to do things to try and slow things down, and it's not going to help. Okay, that right there could be a sign that, because if you look at something like IBS, which can also be characterized by diarrhea, there's ways with fiber, with Saccharomyces boulardii and that sort of thing, that you can actually really get that diarrhea under control. With parasites, there's not much that's going to work. You can have constipation, skin bumps, or rashes. These next two are very telltale as well. So unexplained weight loss coupled with an increased appetite. So I'm just eating, and of course, I'm just not putting on any weight, and I don't understand why. Abdominal pain and cramping, which is unrelated to food. Okay, very, very important here. So SIBO, Candida, bacterial dysbiosis, these are all in direct response to food, right? Within minutes or within hours after eating it. With parasites, everything is very erratic, right? It's all over the place. And people will say, I just can't put this together. Like, one day I ate blueberries and I was fine. The next day I ate blueberries and I wasn't fine. Or, this morning I had gas and stomach pains, and the next day it was in the afternoon. So it's all over the place. You might find that cycles with the lunar cycle as well. In certain times of the month, these symptoms might be more pronounced than others. Okay. And of course, moving on, vomiting, joint and muscle aches, sleeping problems, anemia is a big one, right? So especially anemia where the person is just still supplementing with iron and they're just not getting any better, take a look at parasites, right? And general aches and pains. Now, we've spoken a lot about food. And one of the challenges we have, and I'm not going to belabor the point here, suffice to say that how do we now differentiate between a food sensitivity and an allergy and gut dysbiosis of some kind or an infection, right? Now, I'll just briefly say this. I don't do as much food sensitivity testing as I used to. And the reason why is, as I said, most of these symptoms from a digestive standpoint, 80 to 90% of them are caused by microbes. So it makes more sense to me, obviously, if someone has a bona fide allergy, they're going to know, when I eat strawberries, my skin breaks out in hives. Okay, great. We know that. We don't need to test for it. Sensitivities are a little bit different, right? Intolerances are also immediate. I eat wheat or gluten and I get diarrhea. Easy. Sensitivities are trickier because they are anywhere from, they could be 4 hours after ingestion up to 4 weeks. But usually the way that I approach this is I would rather run things like stool tests and what have you, clean all of that stuff up. And then down the road, if someone says, okay, you know, I'm still reacting to certain foods, maybe that is the time to run a food sensitivity test. Okay, so I just want to throw that out there because things can get very confusing. And I also see a lot of people starting with food sensitivity testing and kind of foregoing stool testing and that sort of thing. And to me, that's really the wrong way around. Okay, so let's jump into some of the functional lab tests here. And before we do that, I just want to discuss some general points of consideration here. The first one is functional lab tests are not diagnostic tests. Okay, very important. They're not diagnostic tests. And the reason why I bring this up is for nutritionists especially, there's this hesitancy to test, right? It's like, oh, I don't want to test. I'm stepping outside a scope, right? I can't diagnose someone. We are not diagnosing anyone here, right? Functional lab testing, listen to the word functional. Functional lab testing means that I want to run metabolic testing to see how you are functioning. And then I'm going to attempt to restore function using natural therapies and diet. Okay, that is what functional medicine really is, right? So it's very important that you relay these types of things to your potential clients or to your clients, because in their mind, I just had this call today with a potential client where he's like, oh, well, you know, I want to see what the doctor has to do first. I want to see what tests they run first. And I had to explain they're running tests to diagnose disease so they can match the corresponding drug. What I'm doing is I'm running tests to figure out why you have what you have, right? Which is vastly different. Also, I want you to ask yourself, why are you testing and what are you testing for? Because functional lab testing has become very, very fashionable. I get people that contact me every week. Can you run a stool test for me? Can I buy a hormone test? Can I buy whatever? And it's important that we run tests that are actually necessary, right? Because going on a big fishing expedition and spending thousands and thousands of dollars of your client's money on things that are not actionable, on things that you can't really work on to get any sort of measurable results, what's the point, right? It's a waste of time. It's a waste of money. So a test is only as good as the person who is interpreting that test. And this is why it's important to actually get some training, right? Obviously, you have to have a starting point. So you have to start somewhere. And I remember the first time I did stool testing, the first time I did any testing, yeah, it was a little bit nerve-wracking and I spent a lot of time figuring it out. But since then, I've taken additional training. I've run hundreds of functional lab tests at this point. So I've gotten really good at interpreting them, right? And lastly, don't forget about symptomatology, all right? There's this tendency now in the functional medicine space to, how do I put it? To treat the labs, right? It's a big problem that I see out there is treating the lab. So I run a battery of lab tests. I get all of this data and I don't really understand symptomatology. I haven't really spent a lot of time with this client to figure out their whole health history and timelines and all this sort of stuff. And what I'm going to do is I'm going to treat the labs. Okay, I'm going to treat the results. That to me is a very unholistic way of approaching all of this. And what I would encourage you to do, because I worked for 10 years, 12 years, probably 10 to 12 years, somewhere around there, with no testing whatsoever, and still got fantastic results. And the reason why is because I mastered symptomatology. And I tell you, the magic, if you take anything away from this presentation tonight, is when you understand symptomatology and you run the right lab test to go with that, and you get confirmation or you get ruling out, what that's going to do for your practice and what that's going to do for your client that's sitting opposite the table from you, their confidence in you is going to go way up and your confidence is going to go way up. And you are going to have a very, very clear path to follow in order to get them well, right? So testing and not guessing is really, really important. Now, as we said in the beginning of this presentation, there are some advantages of functional lab testing. And of course, there are some limitations. So a test, you must run the right test depending on what you're looking for. Okay, and this is why, we'll talk about SIBO testing today, because that's blowing up big time, right? People are talking about SIBO testing all the time. And I'm like, well, a SIBO test only looks at SIBO. That's it. It doesn't look at anything else. So if I strongly suspect that the person might have SIBO and they've tried a bunch of things, maybe I'm going to run that test. But what if I had to expand and look at broader biomarkers and run those types of tests, right? So running the right test is absolutely critical. It's important for us to remind ourselves that no test is 100% accurate, right? There's going to be flaws with everything. As I said before, broad spectrum biomarkers versus narrow testing. I see this all the time. I get people that come to me and they say, oh, I've done a stool test already with my doctor. And I said, okay, well, send me the results. And what do you see? They tested for 3 parasites, sometimes 1 parasite. And I'm like, man, that, you're going to go through all the trouble of testing and sending it to the lab and getting the results. Why not test for 80 biomarkers? Why not test for 120 biomarkers? Let's have a look at overall digestion, at leaky gut, at gallbladder functioning, at pancreatic functioning, and so on and so forth. Why not do that, right? That's a holistic way of looking at functional lab testing. You can get a gauge on overall gut health versus isolated infections, right? So that's really the advantage of running a broad spectrum or a comprehensive stool test as opposed to something very, very narrow. There are major limitations for the small intestine, right? Very, very difficult to test because a colonoscopy, it's even difficult to see what's going on there. But a stool test is only going to, for the most part, is only going to show you what's going on in the colon, right? And that sort of ties in here as well. And there's no real small intestine tests. Okay, so if I do an endoscopy and I put a scope down there, I can get the first third of the small intestine. If I do a colonoscopy, I'm not getting into the small intestine at all. So short of cutting someone open and actually taking a sample, it's very, very difficult to assess what's going on in the small intestine. And what we'll do is we'll talk about some lab testing where we can actually assess what's going on to some degree in the small intestine as well, which is kind of cool. All right, so functional lab tests for GI infections. These are the ones that I really use on a daily basis. I use these the most. Comprehensive digestive stool analysis. The GI map from Diagnostic Solutions is really the most, I would say the best pathogen screen on the market. Of course, with any test, it's got pros and cons. So we'll talk more about that in a minute. The CDSA from Great Plains Laboratory, and then a newer test on the market, which is Biome Effects from Microbiome Labs, right? Very, very robust test and quite different from anything else. The organic acids testing, use this a fair bit as well, and we'll talk more about all of these in a minute. There's OMX, which is a newer organic acids test from Diagnostic Solutions. And of course, the classic, the original OAT test from Great Plains Laboratory. I find myself using that the most, right? That is really their flagship test from Great Plains, and really top-notch, right? So very, very good. And then, of course, SIBO testing as well. SIBO Clinic Canada, if you are not licensed to order functional lab tests, SIBO Clinic Canada is great for SIBO testing. You can literally just send your client straight there. They can order it themselves, do it all, and you get the results, okay, which is great. Genova Diagnostics as well also has a very good SIBO test there. So let's talk about some of these, and obviously, you know, we're under some time constraints here, so I can't go super deep into all of this, but I just want to show you some things and talk a little bit more about some of these data points and what we're actually looking at here. So the first one, you know, for the most part, and I'm talking obviously here in very, very broad strokes, a CDSA will be able to assess the following data points: bacterial, yeast, fungal, and viral markers, parasites, worms, and amoeba, digestion and absorption markers, which is very interesting, right? Inflammation, immunology, which is huge, right? So we know that 70% of our immune system is in our gut. We can actually test and see whether someone's immune system is overreactive, is underreactive, and that all of that can give us very, very good clues as to, has this person been dealing with long-term infections, right? Is it an acute infection that's happening now? Why is their immune system suppressed? So it really gives us some good insight there. General intestinal health, leaky gut, right? Also huge. Sensitivity to antimicrobials, and ABX is antibiotics, by the way. It's just shorthand. and drug and antibiotic resistance. This is huge. So if someone comes to you and says, oh, I've tried everything under the sun, it might be that they've tried the wrong things. And in fact, that the type of dysbiotic picture that they're experiencing is actually resistant to certain antibiotics, herbals, et cetera, et cetera. Okay, more on that in just a second. So this here is what the CDSA from Great Plains looks like. I'm not going to go through all of it, obviously, but what you'll see on the top left-hand side there is you will see expected or beneficial flora. You've got these common cell flora, and then you've got the dysbiotic flora on the right-hand side. Okay, you'll see the legend there. 1+ means there's a little bit, and then 2, 3, 4 means there's a lot. So in this particular case here, we can actually see that Klebsiella on the right-hand side is a 4+. So there's a lot of Klebsiella going on here, and turns out that that's actually involved with some autoimmune issues. All right. Okay, so you'll see here as well, this tests for yeast. And what's cool, I don't know how many species of yeast they test for on this test. I think there's other ones that are much more robust, but nonetheless, they also look for microscopic yeast, which you can see at the bottom left. So sometimes when they can't culture the candida, what they'll still see is they'll find microscopic, and you'll see the legend there where it says expected is none to rare. Sometimes you will see few, or you'll see many, and that's out of range, right? So again, quite sensitive in terms of the testing there. The CDSA also looks at this I think is actually the Genova test, by the way, so my apologies, but nonetheless, they're all very, very similar. So here we can see different parasites, right? So protozoa, nematodes, roundworms, and so forth. And we can see the same here as well. Now, what you'll see on this one here is other markers, right? So we can see things like red blood cells, white blood cells, we can see pollen, and these all obviously mean something once you view this test in its entirety and together, right? Now, what's really cool, as I was saying before, is, what they do with a lot of this, and I think this is, my menu bar is in the way here. Yeah, so this is the Klebsiella. And you'll see on this test, what they do is they culture the Klebsiella. Sometimes they'll culture the candida and so forth, and they will actually expose it to these different antimicrobials and antibiotics. And you can see here that in this particular instance, the things that will work the best are caprylic acid, grapefruit seed extract, and silver. So if this person went and said, oh my gosh, I heard black walnut is awesome for, dysbiosis or whatever, or berberine or oregano, it's not going to do anything. And I've actually had people in clinic that only respond to one type of antimicrobial, believe it or not. And as soon as you introduce that antimicrobial, boom, that's where the magic happens, right? And they start to see a difference. You can see prescriptive agents at the bottom half of the screen. These are really antibiotic agents. And you can see in this particular instance, this Klebsiella bacteria is actually resistant to ampicillin. Right. So if I was a doctor, this would be very, very useful for me to choose the right antibiotic. Now, looking at the GI map, this is what the GI map looks like. So you can see these. This is actually a real live case, by the way. So when you get these types of reports, you tend to go, like, what do I do, right? Where do I start? So this is pretty severe dysbiosis right here. What I'll just share with you very quickly is the way to read this, by the way. You can see, for example, in the top here, 1 to the power of 4, or 1 to the power of 3, or 2, or whatever. And we want to be below that range. So what you'll find is, the way I look at this is, if you look at this Enterococcus bacteria here, you'll see it's 2.7 to the power of 5, and the range is actually below 1 to the power of 4. What that means is it's an order of magnitude out of range. Okay, whereas some of these other ones, look at this one here, this Proteus mirabilis over here is 2.35 to the power of 6, and the range is to the power of 3. So this is very, very high. So the GI map is actually a quantitative measure as much as it just uses DNA. It's actually a quantitative measure for what's going on with the bacteria. Okay, you can also see on that list there potential autoimmune triggers, fungi, yeast, viruses, and so forth. You'll see Epstein-Barr at the bottom there, which is interesting, especially for autoimmune disease. And then you'll see more parasites here, worms, and so forth. Okay, now this one here, in the masterclass that I run, I was very fortunate. I think it was earlier this year. I was very lucky to actually get the doctors from Microbiome Labs to come in, and I think we got about 4 hours of training out of them, which was really cool. So this is the sort of new kid on the block, and it's very, very different in that this is the biome effects test from Microbiome Labs. It's quite different because it really is a functional microbiome analysis. And, you know, a lot of the other tests really laser focus on pathogens, and that's really what their strong suit is. This really opens things right up, and you actually start looking at your gut microbiome index. So overall, and I'll talk about all of these in a minute, if I take my alpha diversity, my beta diversity, my resistome occurrence, so this AMR richness and pathogen index, and I put them all together, how do I score out of 40? And you can see in this particular case, the person is at 20. And what you notice here is alpha diversity and beta diversity are quite low. So this person does not have a lot of pathogens, but if you look at all of their keystone species, these are the beneficial cornerstone species of the microbiome. What do you notice? Low, 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 low. And because these are low, the functions that they perform are also going to be low. So here we see butyrate, propionates. These are all short-chain fatty acids. Production is low. GABA production is low, and so on and so forth. Right, so when we look at this, I'll just briefly share this, and this is very interesting when you look at this alpha diversity. The alpha diversity is how many species does this person have in their gut? So alpha diversity, you can see the healthy range for the US population, because this is a US lab, is about 125 to 200. So this person is down here at the bottom, right? They're right down there. The beta diversity is the richness of the species. And this is a very difficult graph to read because it's actually a 3D image. But this person's beta diversity, this is a different test, by the way. So sorry, just looking at this here, okay? This is a different report, and I can tell that because I can see this value is different. But for that other person, you'll probably find, for this one here, okay, the beta diversity is very low. You'll probably find that if you plot this on the graph, it's somewhere down here, okay? And then your overall resistome index. Now, this test gets very, very granular. I try not to spend a huge amount of time going through all of these points here, but what's really cool is if you recall the main species, the predominant species that we covered in the beginning were Bacteroidetes, Firmicutes, Actinobacteria, and Proteobacteria. You can actually see from the stool test what is the relationship between these. Do I have high Bacteroidetes to Firmicutes, and so on? So this test is about 35 pages long, right, when you get the report. So very, very granular, but boy, you can find some real nuggets when you run this type of testing. So moving along to SIBO breath testing, I think a lot of you are probably familiar with this. It's become very, very popular these days. Essentially, just a very, very short Reader's Digest version here is I drink a solution of lactulose or glucose, and if I have certain bacteria in the small intestine, they will ferment the lactulose or the glucose, and they will produce hydrogen or methane gas, depending on the type of bacteria. They can also produce hydrogen sulfide gas, which is starting to appear. I think people are working on that in terms of testing, but currently all that you're going to find on the report is hydrogen and methane, all right? If I don't have these pathogenic bacteria there, I'm not going to produce hydrogen or methane. Okay, so breath testing measures the hydrogen and methane gas produced by organisms in the small intestine that is diffused into the blood, then the lungs for expiration. Hydrogen and methane are graphed over 2 or 3 hours. By the way, if you're doing SIBO testing, do 3 hours, right? Way better than 2 hours. And then compared to a baseline. And clients or patients drink sugar solution of glucose or lactulose after a 1 to 2 day prep diet. Okay, so I'm going to tell you right now that if you're doing this type of testing, lactulose is superior, and I would do a 3-hour lactulose breath test. So within the first 2 hours, I'll share more on that in just a minute. The lactulose breath test, we would see hydrogen going above 20 parts per million, methane going above 12 parts per million, and combined 15 parts per million. These would all be considered positive. Now, there is some nuance in terms of how we interpret these tests. For example, methane, even as low as 2 parts per million, can cause constipation and motility issues. So it's important to look at the symptomatology combined with the lab test. For a glucose breath test, which I don't do, either gas is 12 parts per million over the lowest preceding level. So this is what it looks like. Very straightforward. It's just a graph. This one here is, in fact, a 2-hour breath test that we're looking at. And it's very important when you read these tests, don't look at the graph, look at the legend on the side, okay? Because this looks pretty flat, right? So you're like, oh, wow, this person doesn't look like they got much going on. But look at the hydrogen levels here. The hydrogen levels are going all the way up to 38, right? Somewhere around there, 28. And so you'll see that this is actually a positive if you look at the legend at the bottom. All right. So this here, this is a 3-hour test. And I'll just tell you this much, that anything after the 120-minute mark, you're getting into the to the large intestine, sorry. Okay, and I think it actually says that over here. So just be aware of that, because the large intestine does produce a lot of hydrogen gas normally. And if you were to look at this level here and diagnose this person with SIBO, you know, you might get it wrong, especially if it's all flat over here and then it peaks at the end. Maybe that's not SIBO. Okay, in this particular instance, this person did test positive for both hydrogen and methane type of SIBO. Right, and that's really it. It's a very straightforward test. You know, it does require some nuance and some interpretation. And please, please, please always match this with the person's symptomatology. Now, what's really cool is on some of the tests that we have now, and what I'm about to teach you is incorrect, but I'm going to share it with you anyway. When you look at stool testing, you know, the big people in the functional medicine space, the naturopathic space, will tell you never use a stool test to diagnose SIBO. Okay, that's what they'll say. However, what we find on some of the newer tests, this again is Biome Effects, we'll actually see that in this particular case, hydrogen sulfide is a marker, which is not tested on a SIBO test. So this person here might be showing all the signs of SIBO. They test negative on a SIBO test, but here they've got hydrogen sulfide is elevated and they've got motility issues. They're reacting to some of those high sulfur foods. So you might stick them on a SIBO protocol based on that result. Also, you'll see methane production here in a stool in the Biome Effects. And again, if it matches the symptomatology, you might stick them on a SIBO protocol and see some really good results. Now, on the GI map, we can actually see sometimes when the phylomicrobiota, these are the real big species in the gut, when both of these are elevated. And we also see the normal bacteria, right? So let me, oh, sorry. You can see that this marker was added to the GI map. This was added about 6 months ago. This again is a methanobacteria. So if that is elevated and they're showing the signs of SIBO, we might stick them on a SIBO protocol. What I was going to say before, just to backtrack a second here, when I see the phylomicrobiota high, and sometimes what I'll see as well is the beneficial flora are all high as well, that is bacterial overgrowth. Even though it's the good guys, we'll see that there's just too many bacteria. And so again, a SIBO protocol can really work wonders for that particular person. So moving on to organic acids testing. Organic acids testing is very common in the functional medicine space. The way that it works is anytime I need to convert something from A to D, I've got to go through A, B, C, D, and we use enzymes, right? We need nutrients to convert the substrates. And so anytime we have a vitamin insufficiency, sometimes we can have certain infections, for example, that will block the conversion of A to B, for example. What will happen is lots of A, which is the organic acid, is going to show up in the urine, and we can then say to what degree is that person deficient, and we can sort of proceed from there. So one thing, I'll just share a couple of things here. One thing to note is that there's a great example here of how Clostridia, all right, so you've all heard of C. diff, I'm sure. The organic acids test tests for multiple forms of Clostridia. And it turns out that Clostridia blocks the metabolism of tryptophan. Okay, so tryptophan is needed. It's an amino acid. We take tryptophan to 5-HTP, and then we take 5-HTP to serotonin, right? What Clostridia infections do is they will block that. So you will not be able to convert tryptophan to serotonin. And what's cool is we can actually check for both of those things on an organic acids test, right? So how cool is it that infections can actually cause low serotonin and result in depression and some other mental health issues, right? So pretty cool. So the overview here, it measures byproducts of microbial metabolism that are excreted in urine. Obviously, we're sort of bringing us back on point here to GI infections. This can provide insight into the small intestine, right? Very, very important here. An organic acids test can give us insight into yeast and fungal markers and bacterial markers that are in the small intestine and or systemic, whereas stool testing cannot do that. So what I'll often see is sometimes I'll see a stool test that'll be negative for Candida, and I run an organic acids test as well, and sure enough, that comes back as positive. This is very, very powerful information because, you know, how many people, they run a stool test and they go, oh, well, you show all the signs and symptoms of Candida, for example, but the test says you're negative, and you never, ever embark on that Candida protocol ever. Right? So having both of these things in front of you, it's a total game changer. This can also provide key information on mitochondrial function, Krebs cycle, neurotransmitters, certain vitamins, not really minerals, right? Some minerals, but mostly vitamins, GI function and dysbiosis. And also some of the new markers will actually also assess detoxification and toxic exposure plus methylation. So a fantastic, cost-effective, broad-spectrum test that really it goes beyond just looking at infections. So if you've never seen a organic acids test before, this is the Great Plains organic acids test. You can see yeast and fungal markers. You know, anytime you can see here, these are out of range. So these are actually circled as being high, but sometimes you'll see that first one there. So citramalic acid, you can see how it's outside of this orange box, right? That tells me that it's elevated, but it's not necessarily very far out of range. And so sometimes what I'll see is I'll see that these are all elevated, but they're not necessarily out of range. And they're showing all the signs and symptoms of yeast and fungal overgrowth. That person, Candida protocol, and go down that road. All right, so more of the same here. Okay, so again, but you can see that there's the addition here of these bacterial markers down below. And if we look at the next slide, you'll see these are all the different types of Clostridia markers that we have on an organic acids test, right? So very, very cool. Okay, very broad, and can give you fantastic insights into what's going on, right? Okay, so let's talk about biofilms here, okay? And I'm assuming everyone has heard of biofilms, even though you might not fully know what they are. Biofilms are communities of microbial cells surrounded by a polymer called extrapolymeric substance, or EPS. Okay, so all that we're saying here in lay terms is these organisms create communities and they build this shell around themselves, which is very, very similar to crab shell, right? They can be composed of single or multiple organisms. You'll see there they can include aerobic and anaerobic bacteria or fungal species. Lyme disease also does that, so the Lyme bacteria, the Bartonella, and so forth. And new research also shows that viruses can create a type of biofilm. This is very important, point 3 here. Organisms communicate via quorum sensing. Okay, this is going to be important when we start segueing into our antimicrobial therapy here. So quorum sensing is where that biofilm as a collective organism made up of these single organisms, they communicate as a unit as opposed to communicating as individuals. All right. And so one of the cool things that we're discovering is we can actually interrupt this quorum sensing, and they cannot communicate, they cannot survive. And that actually helps to gently get these microbes under control. More than 80% of all microbial infections have developed biofilms beginning in as little as 2 weeks from the onset of infection. So this is not new information. This is well known in the medical establishment, very well known. And what we're now discovering is that we are staring down the barrel of antibiotic resistant or drug resistant organisms, right? This is well known. This is well spoken about in the medical literature. And it turns out that biofilm bacteria can resist up to 5,000 times the antibiotic concentration that would normally be needed to resolve infections. So can you imagine this person has these biofilms, they're hiding out, they escape the immune system, they escape antibiotics, but what do people do? What do practitioners do? More antibiotics, right? What do you think more and more and more antibiotics and more antimicrobials do to your keystone species, to all of your good guys? I mean, I don't know about you, but I have seen so many people in my practice that have cycled on and off on antibiotics for years. And you run stool tests and you just see that their microbiome is depleted. And so the new thinking, and we'll talk about this in a minute, a new thinking and a new way of approaching all of this is, instead of whacking people over the head with antibiotics and antimicrobials, can we build that microbiome? Can we strengthen the microbiome? Can we fortify it and make that person more resilient? Okay, so more on that in just a minute. Biofilms in the GI tract often contain something called lipopolysaccharide, or LPS. This is an endotoxin from gram-negative bacteria. This is, to many researchers, this is the most inflammatory and toxic compound known to human beings. Okay, and we can test for it, which is interesting. What this can all do is it can lead to intestinal permeability, and this can translocate the LPS to other parts of the body. Okay, very, very important. So once that LPS lands up in the joints or the brain or anywhere else, it's going to elicit a very, very powerful inflammatory response. And that's why you can see biofilms are associated with many chronic diseases, right, that affect numerous organs and tissues throughout the body. They are very, very difficult to test and to diagnose. And this is even from the medical side of things. So when we look at the 5 stages here, we've got stage 1, which is the initial attachment. 2 is the irreversible attachment. We've got 2 stages of maturation. And then you'll see 5 there is dispersion. Now, what this looks like here, right, is as this disperses and gets out there, what that's going to look like on the outside is a flare-up, right? And then what do people do? Antibiotics or antimicrobials, get everything under control. Okay, whew, right, I'm under control now. And then weeks go by, oh my gosh, I had another flare-up, right? That is one of the signs, which is on the next slide. That's one of the signs that we might go, you know what, maybe this person is dealing with biofilms. Okay, so some of the ways that we can actually tell or when to suspect biofilms: chronic persistent infections and or health conditions. So things like tonsillitis, otitis media or recurrent ear infections, chronic sinusitis, huge. Do you know how many people come in with chronic sinusitis and they're taking all of the nasal stuff and the sprays and everything else? And I look at it and I say, well, you know, there's actually studies published to show that people who suffer from chronic sinusitis actually have fungus and yeast in the gut. So sticking that type of person on a Candida protocol and or testing for it is actually going to help the sinuses, right? Okay, go figure. And 9 times out of 10, they've got digestive problems too. So chronic dysbiosis, in other words, these people have tried everything. The dysbiosis is just not getting any better, and they're cycling on and off, right? Chronic cystitis and periodontal disease or oral disease. Cycling between flare-ups and asymptomatic periods, that's what we discussed before. And when antibiotics provide little or temporary, right, temporary relief, I would actually lump antimicrobials in there as well, okay? And people start getting dependent on antimicrobials, that's a real telltale sign that you're dealing with a chronic infection that is just not budging. Okay, and 9 times out of 10, or I should say 8 times out of 10, looking at the literature, you're dealing with biofilms. So some of the bacteria that are involved with biofilms, E. coli, Staphylococcus aureus, which is heavily involved with skin issues, Pseudomonas, Streptococcus, there's a couple different kinds there, and Klebsiella, which we looked at earlier, is involved with rheumatoid arthritis, UTIs, and dysbiosis. Now, I know I rushed through that, and for good reason, because we don't want to turn this into a microbiology class, but I bring up this slide because many of these are actually tested for in the stool test biomarkers. How cool is that, right? If you look at the GI map, for example, if you look at the biome effects, you will see all of these are in there. And that is fantastic that we can actually test for that. We're not assessing or testing as to whether this person has biofilms per se, but if they've got stubborn infections and they've tried it all and this shows up, maybe you want to start looking at biofilms more and taking that approach. All right. Now, GI biofilms, endotoxins, and chronic disease. You know, the tapestry here is just so huge, and these types of biofilms and infections really wreak havoc on the entire system, right? The entire body. So, immune system issues there, central nervous system issues, mental health, endocrine system. You know, how many people? Because this is my wheelhouse, right? I deal with infections, with gut health, okay, and everything to do with that, hormones and autoimmunity. Well, why is it that when people come in with hormone issues, when people come in with autoimmune disease, why am I looking at the gut? Why am I running stool tests on that person? Yes, we're running hormone tests too, but the reason is you can trace back a lot of this stuff. You know, autoimmunity, one of the 5 root causes of pretty much all autoimmune disease, is an infection of some type or infections. So it only makes sense to look at that first and then really start to dial into the granular side of autoimmunity. And oftentimes we'll find, you know, things like Hashimoto's, for example. You will find that oftentimes there's Epstein-Barr virus there, there's leaky gut, there's other stuff going on. All right. Blood sugar issues, joint and muscle issues. So, you know, chronic fatigue syndrome, fibromyalgia. How many people out there walking around with chronic fatigue syndrome that have just been thrown out into the cold with a almost like a throwaway diagnosis and no help at all? And of course, GI tract issues, right? Periodontal disease, and you know, you can see what's on there on the slide. So the point being here is that these types of infections and the biofilms that they create, which is 80% of cases, wreak havoc in the entire system and have these seemingly unrelated effects, right? Whether it be mental health, whether it be blood sugar issues, and so on and so forth. So it's very, very important for us to dig down into the roots. And this is why I firmly believe that digestion and gut health is at the root of pretty much all disease. All right, and I've seen it in practice. So let's shift gears a little bit and talk about redefining our understanding of the microbiome and infections, right? And I've sort of alluded to some of this coming up. So the first thing that we always need to acknowledge is that dysbiosis is a symptom of other underlying problems, right? Very, very straightforward. You know, SIBO, for example, you've got these giant SIBO masterclasses and they get so granular. And I'm like, but why does the person have SIBO in the first place? What else is going on? And so asking yourself why, and tracing it back to its origins and working on the root causes, that's where the magic really starts to happen. So as we've discussed, poor digestion, which we've looked at already, poor diets, right? So low fiber diets, excess sugar. What about low dose antibiotics in food? Okay, so if people are not eating predominantly organic, glyphosate or Roundup, pesticides, okay, the list goes on, food additives, there's a whole bunch of things that can really disrupt the microbiome there. Glyphosate is huge, by the way, right? Roundup, absolutely catastrophic, because what glyphosate does, just to get a little granular here for 1 second, is it actually disrupts what's called the shikimate pathway. So the shikimate pathway in weeds is a very important metabolic pathway. And the way that glyphosate works is it basically blocks the shikimate pathway and kills the weed. Well, it turns out that they didn't ever look at bacteria in the gut. And it turns out that bacteria also have shikimate pathways. So the glyphosate in low doses on a daily basis is actually killing the microbiome. Okay, and this is why going organic is very, very important. So we've spoken before about creating a favorable environment for dysbiosis, and there's many different things that tie in there. There's problems with long-term restrictive diets. I see this a lot. How many people go on a low FODMAP diet and never ever get off it? Or they go low carb or no carb, or Candida diets. I had a person once, you probably won't believe me when I tell you this, I had a person that had been on a Candida diet for 10 years, and still had Candida. So the thing that we need to acknowledge with this, and the reason why I bring this up, is I am not a huge fan of long-term restrictive diets. That's never the goal. A short-term restrictive diet that is therapeutic in nature is fine, but we should be trying to open up that diet at the right time. Okay, so for example, and why is this a problem, right? So why is it, I'm very interested to see what's going to happen with the carnivore crowd, with the keto crowd in the long run. Because much like no society has ever been vegan, historically speaking, there's also no society, I don't think, aside from maybe the Inuits up in the North Pole, that have been 100% carnivore. And what we're starting to see now, and I've learned this from other doctors, is we're actually starting to see that people who are on these high protein, low, no carb diets, you actually see it reflected in their microbiome. And all of this to say that when we restrict these foods, right? So there's nothing wrong with carbs, right? A lot of those FODMAP foods, very healthy foods. There's a lot of foods that are Candida triggers that are very healthy foods. But these types of carbohydrates, these fibers that we find in there, they feed all of the beneficial or keystone organisms. So if we restrict ourselves for too long, we're not just restricting the Candida or the SIBO, we're actually restricting our own microbiome and our own good guys, which what it does is it paints us into a corner. And this is why people get very, very trapped, right? And they go, oh my gosh, well, every time I try and reintroduce something, I blow up. What that tells me is that you haven't shifted the balance. Okay, so shifting that balance is really, really key. And there's ways to do that, right? So more on that in just a second. I'm going to get to the questions at the end, if that's okay. And we'll chit chat a little bit. So it's important to look at these dysbiosis patterns. Does the person have low keystone species and high pathogens? Okay, let's just pause there for a minute and think about what that is saying. I have low probiotics and beneficial organisms, and I've got high pathogens. What would happen to that person if I went in there guns blazing with antibiotics and antimicrobials? I'm going to get the pathogens down, but I'm also going to deplete those keystone species even more. Okay, so that is going to require a slightly different approach to low keystone species with no pathogens. This person here, we might not be looking at antimicrobials at all. We might simply be saying, oh my gosh, this person needs prebiotics. They need probiotics. What strains are they missing, right? And so on and so forth. And we can contrast that with a third scenario here of high keystone species with high pathogens. Well, in that case, I might go a little bit harder on the antimicrobials because everything is elevated. So going on antimicrobial therapy and then repopulating or changing the diet, that might be the situation here for the scenario number 3. But the point being is what we're looking at here is we're looking at a bigger picture scenario here, and we're also looking at a more nuanced approach as opposed to just saying whack it over the head with antimicrobials and then repopulate and deal with the collateral damage down the line. And that sort of segues here into reinventing antimicrobial therapy. I've started experimenting a lot with this in the last couple of years in practice. I think when we think about the traditional way here, what we'll see, and this is still standard practice right now, is the 5R approach. And I have a lot of respect for the 5R approach, and I've practiced it for a really long time, and it works. But as science evolves, as our understanding evolves, as the research on the microbiome evolves, I think we need to evolve with that. And we need to maybe start stepping a little bit outside of this 5R approach and combining some of these steps together. So what we want to really pay attention to here is we want to preserve those keystone species. Okay, I see people with species that are absent. And let me share one little tidbit here as a side note. I have now started to see less microbial diversity over the last couple of years. And when I spoke to a few of the doctors, they've actually said to me they've started seeing the same patterns, and they suspect that it's because of lockdowns and it's people staying home more, not going into social settings and stuff like that. And we're now actually seeing that reflected in the microbiome, which is very, very interesting. And what that's going to do is, obviously, the knock-on effect is digestion, immunity, all sorts of other knock-on effects are going to start to happen. All right. So point 2 here is we want to use antimicrobials as little as possible, and only when we actually need to. And couple that with repopulating as quickly as possible. Right. Very interesting here. You know, in a lot of the protocols and the way that I do things, they tend to be quite drawn out, right? And I'm sure a lot of you are doing the same thing, where, you know, we're following the 5R, we're removing first, and then we're repopulating and replenishing afterwards, right? And I've always sort of had like there's 3 different schools of thought. One is wipe things out, repopulate after. One is wipe things out and repopulate at the same time. So maybe you would do things, antimicrobials during the day, repopulate at night. And there's a third one, which is saying that we can actually take everything together. And there's a fourth one, which is sort of now starting to sort of gain a lot more traction, which is it possible to actually crowd out these pathogens with probiotics and prebiotics? And this does require some nuance because, you know, for example, if you've got someone with SIBO and you just go and throw a whole bunch of probiotics in there with prebiotics, that person is going to blow up, right? They're not going to have a good time. So there is some nuance here, and you do have to evaluate this on a case-by-case basis, but it's exciting to know, and I'm doing it. I'm doing it in my practice, and I'm starting to see that we can speed up this whole process, where instead of 3 to 6 months of, you know, lots of detoxification, lots of antimicrobial therapy, then move into the repopulation and reintroduction, we're starting to shorten that treatment phase now, and we're actually starting to see results are starting to happen in a much shorter space of time, which obviously is very encouraging, not just for us, but also for our clients and patients. Okay, so we can use spore-based strains. We can also consider rotating strains. What's cool is when you want to get really granular, you can actually see on some of the testing that there's certain strains of beneficial bacteria that feed on certain substrates, that feed on certain types of prebiotics. So having those types of tests in hand can really help you to dial in what types of foods that person should be eating and what types of prebiotics are really going to help feed their microbiome. Okay, very cool information. So we can also use immunoglobulins and binders to help mop up the microbial die-off. Okay, so that's also, I'm using those a lot these days, and they work really, really well. And of course, we can round all of this stuff out by using liver and gallbladder support to minimize Herxheimer or detox reactions, right? So when you start putting all this stuff together, you know, your clients and patients are having a much better time embarking on these types of protocols, and you can also speed everything up and get results a lot faster. Now, we can also disrupt biofilms and pathogens in a number of ways, right? So we can use botanicals to inhibit quorum sensing. We can inhibit the initial attachment phase. We can inhibit the swarming motility. We didn't really talk about that. There's broad spectrum antimicrobials, and flossing and oil pulling disrupts oral biofilms, okay, which then prevents translocation to the gut. So a lot of things we can do here. And I want to be quite clear that what we're going to share in the next couple of slides, we don't have to use it all, and we also don't have to use crazy high doses. All right. Remember, we want to look at the whole. So here we can see that garlic, oregano, bilberry, bladderwrack, and golden seal, these all inhibit quorum sensing, okay, which is huge. We've got curcumin and quercetin, for example. They reduce the metabolic activity of biofilms. Oregano, tea tree, cassia, thyme, and so on. These are all antimicrobial essential oils. Now, we're not talking essential oils like Young Living or doTERRA or whatever. We're just saying that the oils in there, they have antimicrobial properties and they can prevent the adhesion of biofilms. And we've got thymol, which is a compound in things like thyme, black cumin seed, and other phenols. They interrupt the initial attachment phase. You know, this is just the way I practice, but many years ago, I started veering off single remedies. Okay, you know, I'm a protege of Bernard Jensen. I was taught by one of his sort of star students, if you will. And Jensen was always use single herbs in high potencies. And I've kind of, you know, really fallen out of favor with that. And I think that using broad spectrum in lower doses, particularly for things like this, actually has less collateral damage and impact on the overall microbiome. And it has a much more subtle effect in terms of balancing out the dysbiosis and helping the overall microbiome. All right. So some more here. So these are also compounds that will disrupt biofilms. So arginine, grapeseed, berberine, tannins. You'll see NAC, right? Very popular these days as well. EDTA have all been studied with regards to biofilms. We can use proteolytic enzymes to help break down that shell, the outer shell of the biofilm. Okay, immune supporting compounds to enhance biofilm treatment. Remember, people with biofilms and chronic infections, their immune system is depleted. So we can actually use things like shiitake, one of the best medicinal mushrooms for this particular application, echinacea, immunoglobulins, colostrum. There's great homeopathics in there as well. Okay, we can use all of this. Now, I know, you know, when you look at it all like this, you're like, oh my gosh, how many supplements is this person taking? You don't have to take a lot of things, right? You just have to take the right things at the right time. And you also have to look at broad spectrum formulations, right? That really provides a lot of synergy, I find, and works very, very well. So some framework here, framework for general dysbiosis. As I mentioned earlier, you know, the 5R approach is still current standard practice. This is taught in all the schools. This is, you know, taught by the labs. And I think that, you know, over the next few years, I think we're going to start to see this 5R approach evolve a little bit into something else. Antimicrobial therapy followed by repopulation. So again, I want you to go back, you know, you can go back and listen to this and just think about those scenarios, right? You know, what does the testing reveal? Are all the bacteria high? Well, in that case, antimicrobial therapy followed by repopulation might be good, right? If you see a different scenario, antimicrobial therapy together with repopulation might be indicated. And for very mild dysbiosis, we can actually avoid antimicrobials altogether. We can crowd them out with probiotics, prebiotics, diet, and lifestyle. And my biggest takeaway here is don't try and fix everything at once. All right? Trying to fix everything at once is guaranteed to overwhelm your clients. It's going to overwhelm you. And they're just going to be taking boatloads of supplements, and you're not going to be able to see what's doing what. Okay, so actually having a bit more of a, you know, what I call a wellness roadmap. That's what I teach practitioners: wellness roadmap, and just come up with, you know, here's point A, there's point D. How do we break this up into chunks and sort of work you into that, as opposed to just throwing the kitchen sink right out the gate. Okay, so before I hop into, I will share with you, because I'm sort of at the end of this presentation here, I do want to, before I leave, I will share with you my Digestive Health Practitioner Masterclass. So we'll get into that in a minute. Very briefly, I've got a couple of slides on that, but I wanted to take this, there's a question here. So we will potentially see even more gut issues from COVID shots and infections, quite possibly. Yeah, I think time will tell on that front. All right. So if I can, what I will do is just share with you what's going on right now. We have opened up enrollment. This program has been going on for, I think it's the 3rd year now. All right. So this is a bona fide digestive health masterclass. We go very, very deep into a lot of, well, all of the main ones, right? So the main types of health issues or gut health issues that you would find in practice, we go deep into it all. It took me a few years, but I basically wrote a textbook that goes with that. So fully referenced protocols. I get into a lot of the, just some of the diagnostic stuff. So from the medical side of things, what are the actual diagnostic criteria? What is the medical treatment and how do they approach things? And then, functional lab testing, nutraceuticals. I'll bring up the next slide here. So we've got protocols, obviously, so full protocols and guidelines, food lists, meal plans. I'll basically share with you and expand on what we've discussed tonight in terms of what functional lab tests to use, when to use them, and all that sort of stuff. And there's a whole bunch of other things that's included there, including a therapeutic dosage guide. We've got a certificate of completion, which is optional. That is issued through the Institute of Holistic Nutrition. And the feedback, I think we've had about 155 practitioners go through this now, and the feedback has been great. And what's encouraging for me anyway is, after almost 20 years in practice, to be able to take a lot of what I've done and developed and to teach that to practitioners and see them implement it into their practice, and then come back to me and say, oh my gosh, this stuff works. And what's really cool is to just see, a lot of younger practitioners out there now that are blowing up Instagram, and they're really becoming gut health experts out there. And a lot of them will say, oh, it's because I went through your program, I feel so much more confident now to actually tackle these more chronic and complex issues. And that is really the differentiator, right? Because I think when you look out there, there's no shortage of summits and, podcasts and all that stuff to listen to. But how do you bring all of that information and anchor it into something that's actually doable for you in your practice, right? And sort of rinse and repeat systems. So we're kicking things off June 20th. There will be 5 weeks of live online classes. And then I've got a whole bunch of other content that I'll slowly start dripping out as we get into that. But basically, you have lifetime access to all of the content beyond the 5 weeks. And if you are looking to get the certification of completion through IHN, you will have to complete everything in 6 months. Okay, so go through all the trainings and contents. We actually have a bunch of, there's training with microbiome labs. We've done one with biotics research as well. Fluids IQ Labs came on and did one as well. So we've got a bunch of extra bits and bobs there as well. And of course, I will also let you know that you are entitled to $500 off, which is basically 33% off the actual price. And that is really for my people, for my nutritionists. All right. So I'm going to stop share my screen. And I see, Veronica, you did not lose signal. So that's great.
I'm here, yes. First of all, Brett, I want to say I have had the opportunity over the years to attend many of your webinars and lots of different courses, but this one was amazing. I don't know if I should say, I think it was the best. That was a lot of information in a short amount of time. Thank you so much.
You are most welcome. Thank you for having me. As you can tell, I love talking about all this stuff. I geek out on it. And, honestly, for me, the reward is actually, not just seeing this stuff happen in my own practice, but I realized years ago that if I wanted to really have an exponential impact on people's health, I needed to start training and coaching practitioners. And this program that you see in front of you took me a long time to put together. A lot of how do I relay this? How do I put it down on paper? How do I teach it? And so it's very exciting for me to see practitioners implement this now after 3 years and come back to me and say, wow, this stuff really works, which is very exciting. Yeah. So good.
That's amazing. I was just double checking in the chat. I don't see any other questions or anything coming through. So maybe we'll give everyone one last second if they have an urgent question that they want to ask about anything that they just saw. I did see you had noticed Connie's comment about how things relate to the pandemic and gut health. And you sort of touched on that even with the lockdown effect and how that is impacting people's microbiomes. And I mean, we had the whole world over dousing themselves in antimicrobials many times, most days. So
Yeah.
I know I'm seeing it in private practice, and I've heard from a lot of others that they're seeing a lot more gut health issues and issues with the immune system.
Yeah, and I think about the kids, right? And kids now, I worry about what the next couple of years is going to look like. I have a daughter that was born in the middle of a pandemic. Like, she was born July of 2020. So with her, I noticed, even just from a developmental standpoint, there was a lot of social issues and stuff, which she's now got over. But I'm so grateful that she's now in a daycare setting. She's coming home with green snot on her nose. I let her run around in the dirt and whatever. And it's like, yeah, let's just build up that microbiome and let's get your immune system up, as opposed to taking the other approach, which is antimicrobials, hand sanitizer, like completely sterile environment. That's just not how nature is. It's not how we're designed. And as I'm seeing on these stool tests now, this is really, I think, is going to start to backfire in many different ways. And you look at what's coming down the pipeline and what the conversation right now, a lot of these obscure viruses that were hidden, that were not a feature before, are now suddenly coming back. And some of the hypotheses around that are because of a weakened immune system, because of isolation, because of being cut off from society. So yeah, I think time will tell, but I'm optimistic, because the cool thing is that we actually have the tools right here. I mean, we have the tools that we can actually strengthen people's immunity from the ground up. And that ripple effect on whether it be blood sugar, osteoporosis, mental health, whatever it is, we have the tools and to analyze that, to figure out what's going on, and then to actually implement some remedies, which is very exciting. So
yeah, such a great point. Yeah, there's definitely a lot of hope there and empowerment that can be offered with this information.
Totally.
I don't see any other questions coming through.
Okay, awesome.
So I think you are free for the evening. You have shared enough. That was a really wonderful presentation. Thank you again.
Awesome. Thanks so much, Veronica. And thanks everyone for attending live. We'll catch up with you soon.
All right. Take care, everyone.
Okay.
Bye-bye.
Thank you. Bye.